Patient Cassie Fisher is a 52-year-old female presenting with severe abdominal pain. HPI includes an onset of 1 week ago, gradually getting worse. Location is right upper quadrant. The duration is severe for the last 24 hours. It woke her from sleeping. The character is constant and achy. There's no aggravating factors. Relieving factors is Advil. She has not received treatment for this in the past. The treatment of Advil does reduce the pain to 3 out of 10 from a severity of 7 out of 10. Her current medications are Advil 4 to 600 milligrams Q4 for abdominal pain times 6 days. Daily. She takes simvastatin 20 milligrams, glyburide 5 milligrams, metformin 1000 milligrams, lithium 300 milligrams, and quetiapine 400 milligrams PO. She has no known allergies. Past medical history is diabetes type 2 and dyslipidemia for 7 years, bipolar disorder for over 30 years, and she is unsure which type it is. Past surgical history and hospitalizations includes a partial hysterectomy 5 years ago related to fibroids and excessive vaginal bleeding. Family history of her mother having type 2 diabetes and hypertension for the last 10 years. She is alive. The father did pass away from non-small cell carcinoma of the lungs at the age of 77. She has a brother and sister with uncomplicated health history. Social history includes single African American female working as an actress and singer. She is high school educated, lives alone, denies drug use, drinks 2 to 3 alcoholic beverages a day, and has a 32-pack history. Patient denies wanting cessation assistance at this time. Patient feels her bipolar is well managed and denies thoughts of harms to self or other. Review of systems is unremarkable with exception to gastrointestinal. Patient complains of nausea, vomiting, abdominal pain 7 out of 10. That is constant achy in character for 7 days and increased severity for the last 24 hours. Patient denies diarrhea, constipation, hepatitis, hemorrhoids, eating disorders, ulcers, black tarry stools. Last bowel movement was 2 days ago and normal. For cardiovascular, she denies chest pains, palpitations, P&D, orthopnea, or edema. Respiratory system, denies cough, wheezing, dyspnea, pneumonia, or history of tuberculosis. Her vital signs are stable with 134/84 for her blood pressure. Respiratories are 16, sodium 97%. She has a pulse of 92. She's afebrile. She's 5'6", 150 pounds, giving a BMI of 24.2. Focused physical exam findings include an uncomplicated cardiac and respiratory assessment, but in addition to having complicated abdominal findings that include severe tenderness to touch during inspiration while palpating the gallbladder fossa. Voluntary guarding noting to right upper quadrant during palpation. Bowel sounds are active in all 4 quadrants. Abdomen is soft. No hepato or splenomegaly identified at this time. She does have a positive Murphy's sign with no rebound tenderness found. Differential diagnosis, so we have pancreatitis as she's presenting with nausea, vomiting, abdominal pain. Elevated triglycerides and smoking can contribute to pancreatitis, so it's important to note that in her history. We have also cholestasis with common symptomology of biliary compromise producing right upper quadrant pain. We must also consider the patient having intrahepatic contribution due to the polypharmacy effects and drinking every day. Acute cholecystitis with symptomology and increasing right upper quadrant pain over the last 6 days with elevated severity over 6 hours that woke her from sleeping and a positive Murphy sign. Diagnostics that we're going to get are a CBC with DIF to rule out or confirm presence of active infection. Obtaining a baseline hemoglobin and platelets is also a good thought if surgery is imminent. A CMP to assess electrolyte imbalances. An elevated ALT and AST could indicate liver involvement, and bilirubin to assess if cholestasis or cholangitis is connected to an elevated white blood cell count. Alkaline phosphatase, when elevated, indicates could indicate an obstructed biliary system. A UA to evaluate for a bilirubin, blood bacteria, white blood cells, or nitrates in the urine related to rule out polynephritis. An abdominal ultrasound was taken, and it did reveal multiple calculi under 4 millimeters with a clear common bile duct. If we could not visualize that, we would get an abdominal CT with axial contrast to enhance those gallstones. So our final diagnosis is acute cholecystitis related to patient presentation of nausea, vomiting, increased right upper quadrant pain over the last 6 days with elevated severity over 6 hours that woke her from sleeping and a positive Murphy sign. Diagnostic data confirms this diagnosis via ultrasound revealing multiple calculi and thickening. Supportive risk factors specific to this patient include her female gender, age, diabetes, and dyslipidemia. Our plan of care is immediate transfer to the ED for specialist evaluation and likely surgical intervention, as that is a standard of care for acutely symptomatic patients. Medications would include IV fluids like normal saline, antiemetic, Zofran, and Reglan, pain control with Toradol and morphine, infection management and prevention with cefazolin. Non-pharmaceutical recommendations, definitely want to keep this patient NPO and educate her about that so she doesn't eat on the way, relaxation, breathing techniques, biofeedback, rest, low-fat diet. Referrals would include the ED, gastroenterologist, or general surgery consult. We want to educate the patient of this disease process, reassure her about the plan of care, and consider things that are culturally sensitive, like historical mistrust. She will follow up in 2 weeks post-op unless complications arise sooner. Thanks.